Thank you for the opportunity to present this trial. I just want to acknowledge immediately the 16 other co-investigators in 4 countries who contributed patients to this trial. It was truly a multi-centre effort. Fibrin pad's a new hemostatic product based on oxidised regenerative cellulose with vicral fibres placed into one side to increase the surface area and human fibrinogen and thrombin bound to those fibres. The pad is applied to a bleeding point in the operative field with subsequent activation of the coagulation factors and adherence of the pad to the bleeding. This was a phase 3 trial that was randomised to compare the fibrin pad to standard of care for hemostasis at 4 minutes following randomisation and then 10 minutes in at fascial closure. We also wanted to address some safety issues. We stratified for the type of liver resection, which was anatomic versus non-anatomic, and the type of underlying liver parenchyma, which was normal or versus abnormal. IRB approval was obtained at each of the sites, and the sample size was based on previous clinical trials. We had an interim analysis at 90 patients, and there was an independent DSMB and clinical events committee. All investigators attended full-day animate labs to ensure the conduct of the trial was consistent across the different sites. Subject eligibility shown here, essentially anyone having elective hepatic surgery greater than 18 years of age and consent competent. We specifically did not include patients undergoing surgery for trauma, transplant for fulminant liver failure, and those with perihepatic sepsis. This is if you could just click on the video, please. This is a demonstration video of a target bleeding site following a non-anatomical resection. This is the sort of site that needed to be identified by the surgeon intraoperatively, and it needed to meet those 3 criteria, so it didn't respond to manual compression following over 30 seconds, was persistent and required the surgeon's input, and preferably where conventional measures of control were inappropriate. Doesn't look like that's going to play. This is the trial timeline, so patients were seen in the clinic, and then during surgery, once the surgeon had found a suitable target bleeding site, randomisation occurred. We either applied fibrin pad or standard of care, and hemostasis was assessed at these timeframes after randomisation. Patients were then followed in the ward and then as outpatients on day 30 and day 60. Subject disposition, so we had 211 patients screened, 102 that were randomised, 50 to the fibrin pad group and 52 to standard of care. Looking at demographics, the groups were reasonably well matched in terms of patient age, gender and ethnicity. Metastatic colorectal cancer formed the bulk of the indications for resection, with some primary liver tumours, some benign tumours. There were 3 split liver transplants included, and then a group of other resections for other indications. 50% of patients exactly in the fibrin pad group had anatomic resections, a little less than that in the standard of care group. In terms of the hepatic parenchyma, 78% of the fibrin pad group, 69% of the standard of care group had normal parenchyma. In the abnormal group, cirrhotics predominated in the fibrin pad group, steatotics in the standard of care group, again reflective of sort of modern surgical practice. In terms of the target bleeding site size, this was measured directly intraoperatively, generally 6 to 7 square centimetres. Venous bleeding was the most common, with arterial and mixed splitting it. The actual transected area, so the area of parenchyma that the target bleeding site sat in, tended to be obviously much larger, and this was the standard of care group. 16 patients had manual compression only with a gauze swab for 4 minutes, and the bulk of them, 36, had manual compression with oxidised regenerative cellulose. Operative information, surgery tended to be about 3 hours, but obviously quite a range. ICU stay about 3 days, but again quite a range. Patients spent about 8 nights in hospital. Blood loss as measured with swab weights and suction volumes was similar in both groups, but less of a transfusion requirement in the fibrin pad group during their admission, and surgical drains were used according to surgeon discretion. Adverse events are summarised here. So these are events that occurred in greater than 5% of people in each group. Again, quite a range, but really reflective of those things that we see in patients undergoing surgery of this magnitude. The primary endpoint, this really summarises it, and for all the cases, 96% versus 46% for standard of care, treatment difference of nearly 50%. For anatomic resections, again, statistically significant difference. Non-anatomic resections, an even greater difference, which is interesting given the problematic nature of those resections at times. In terms of parenchyma, normal versus abnormal, fibrin pad was effective in both settings. The adverse events, so similar numbers of adverse events recorded in both groups, 18 and 25 serious adverse events. I guess the elephant in the room with this is the potential bleeding events and the potential thrombotic events. There were 3 bleeding events in the fibrin pad group, 1 patient with an unexplained anemia that wasn't transfused, 2 wound hematomas, 1 wound hematoma in the standard of care group. All the wound hematomas didn't need any intervention. 2 thrombotic events in the fibrin pad group, subclavian vein thrombosis in a patient with a central line and a portal vein thrombosis, and it was deemed not related to the product. 1 death in each group related to liver failure. 1 event possibly related to the product in the fibrin pad group, which was an intra-abdominal collection treated with percutaneous drainage. So the conclusion is that the fibrin pad is a safe and effective hemostat when applied to treat parenchymal bleeding following hepatic surgery, and this functions across all hepatic resections, including non-anatomical resections, and it also functions in both normal and abnormal parenchyma. Thank you very much.